It is just a huge honor for me today to be podcast interviewing Dr. David McIntosh, MBBS, which stands for Bachelor of Medicine, Bachelor of Surgery. It's the same thing as the USMD. FRAX, which stands for Fellow of the Royal Australian College of Surgeons. PhD, which stands for Doctor of Philosophy. He's a pediatric ENT specialist in Australia with a particular interest in airway obstruction, facial and dental development, and its relationship to ENT, ear, nose, and throat airway problems, and middle ear disease. He also specializes in sinus disease and provides opinions on the benefit of revision of previous sinus operations. He is also passionate about indigenous health. He has undertaken advanced surgical training in ENT and head and neck surgery, pediatric training at Starship Children's Hospital in Auckland, New Zealand. He's a strong advocate for teamwork in healthcare, and in particular on the topic of sleep disordered breathing. He's the author of 2 books, Snore to Death and Don't Ignore the Snore, both of which are available on Amazon as print and Kindle versions. He has been running education courses on ENT for dentists for over a decade. His achievements include a PhD thesis relating to healing after sinus surgery, which got him a scholarship deal. He published in peer-reviewed ENT journals throughout the world, present on ENT throughout Australia and overseas, fellow of the Royal Australian College of Surgeons, fully compliant with the Royal Australian College of Surgeons. But I kid you not, if I read his resume, it'd be the whole hour. He's just that amazing. And then the other guy, Dr. William E. Harrell Jr., DMD, who goes by Bill, graduated from University of Alabama Dental School in '75, then pursued his orthodontic residency at the University of Pennsylvania in '77. He has been interested in 3D imaging since the early '80s, and also how early airway issues in children can cause altered growth and development, malocclusions, and co-morbidities from sleep disorders later in life if left untreated. The face, jaw structure, TMJs, and airway space are three-dimensional and interrelated. He's worked and taught with the pioneers of TMJ disorders from Bill Farrar to Bill McCartney of Montgomery, Alabama, Normandy Study Group for TMJ dysfunction. Dr. Farrar was a doctor who correctly explained the clicking anterior disc displacement with reduction and locking anterior disc displacement without reduction and pain and dysfunction that occurs in the TMJs. Dr. McCartney was the oral surgeon who developed the TMJ disc repair. But Dr. Harrell also got interested in the early 80s about how airway dysfunction may lead to altered craniofacial growth problems and malocclusion in children, and how this may lead to obstructive sleep disorder later in life. He has studied with some of the biggest pioneers, Stanford University, where sleep apnea was discovered. This has led to a passion, early diagnosis with 3D imaging. And weren't you the first to get a CBCT in Atlanta or something crazy
in Alabama?
Like that? In Alabama?
First in Alabama. Yep.
First in Alabama. That is amazing. And gosh darn, this is going to be so darn fun. So I have to tell you, I can't believe I'm interviewing you guys, because when I got out of school in '87, they never even mentioned sleep one time. I mean, it never even came up. It wasn't even a thought process. And then out of nowhere, you know, it's just all over the world. I assume by looking at us that me and David breathe properly, since we have proper bald heads. And Bill, man, you're not sleeping well, buddy. You got a bunch of hair on your head. But Bill, why did you see this so early? How did you know this was a big thing before it was a big thing?
Well, in the 80s, I think around 1982 is when Harrell did the monkey studies, where they took young monkeys. I had just gotten out of ortho school in '77 and set up my practice, and doing traditional stuff. And then in '82, there was an article that came out from Harrell where they took little young monkeys and to stop their noses up, and then it basically created a set of malocclusions in young monkeys that don't get malocclusions. So, kind of a light bulb went on, and I said, well, we've been trained that genetics is a big factor, and it is, but there may be more to this. Melvin Moss talked about it too, and the growth and development with the functional matrix theory and things like that we learned in school. Of course, we kind of learned it for the test, and then we kind of forgot about it. But I think the monkey studies kind of brought it to light. And then also there were others that followed Dr. Harville, Jim McNamara, and some others in orthodontics that started talking about airway, and Dr. Frankel in Germany was using his appliance early on in the 80s and showing some amazing results. And then the airways were kind of talked about. But then in 2001, of course, the first cone beam was introduced in the United States. Dr. Joe Caruso at Loma Linda and Dr. Hatcher, David Hatcher, who's an oral radiologist, a good friend of mine. But he claims to have he got it the next day and claims he's the first one to use it. So I kind of waited on David Hatcher to give me the go-ahead about when would be the best time to get cone beam, and we got ours in 2005. And so that kind of opened a whole nother door about the structure and the airway that we could see. So that's kind of what led me down the path. And then, of course, I got introduced to David McIntosh, and that kind of opened my eyes to a whole nother set of circumstances.
Well, you know, when you say monkeys and the research on monkeys, what's blowing my mind is why I didn't hear this from the orthodontist first, but the anthropologist for several years now keep publishing papers saying, this whole ortho thing, we really don't see it when we studied old hominid fossils. And there's a lot of people saying, where did all this come from? Because you can go back from, you know, a 2,000-year-old skull all the way to Lucy and not see what we're seeing. So
exactly.
David, what do you think that's all about? How come cavemen and Neanderthal and Peking man and Homo habilis and our Australopithecus, why do we have it and none of them did?
I think thank you first of all, Howard, for having us. This is a fabulous opportunity. I think we're basically in the middle of what we could look at as a perfect storm in terms of theory. So if we look at how things have progressed over time, we go back to our genuine ancient ancestors. They did not have fire, and they would then have to consume meat as part of their diet without the benefit of fire. And that was extremely difficult for them. The meat was very chewy, and the advent of fire made it easier. And then the advent of processing and machines made it easier. And we now find ourselves in a situation where if you go into a usual supermarket, pretty much 80 to 90% of the space is taken up by food that's processed, nothing that's in its genuine original state. And a lot of that food is soft and mushy. So we have a dietary change from that point of view. We also have an inflection point with the advent of the development of milk powders and so forth as a substitute to breastfeeding. So we have that change. We have a transition from living out and amongst nature to basically being contained within four walls. And there's a progress there of then a change to the exposure to the environment that's seeing a spike in allergies. And those allergies include nasal allergies, which then causes a blocked nose and mouth breathing. We are really just in the middle of a whole paradigm change of existence, whereby our exposure to the natural elements is really quite divorced, because we've generated machines and technology to make our lives more comfortable. But in the process, we have these things going on. The other two things, at the very least, that have happened evolutionary is our brains have got bigger. And as our brains have got bigger, the configuration of the skull has had to change. And the other thing is we've gone from a walking on all fours to an upright posture. In the process of doing that, there's had to be some biomechanical and anatomical changes. So there's a lot of things that have happened in evolutionary terms all at once. And realistically, as you've alluded to, you know, if you look at sort of what's happened over the past 10,000 years, the archaeologists and the anthropologists that follow really are telling us that what they're observing and what we're interpreting don't necessarily, as you've said, match up quite as they should.
Yeah, my gosh. So do you think in the near future, orthodontists will be holding seminars in their office on Saturday for pregnant mothers to say, hey, come to my course and prevent malocclusions instead of, breastfeed longer. And if the baby fights a little bit, you don't switch to a sippy cup that just pours milk in with zero effort. But I mean, that I read things that probably humans used to nurse for several years, and you probably just threw them a bone and they chewed on it, but they didn't have any forces on their face. Do you think orthodontists that will be the marketing thing of coming near soon? How to change your behavior to have babies that grow up to look more like cavemen?
Well, yeah, interesting, interesting alternative. I can actually answer that and inform you. At least here in Australia, is that we have at least one that already does that very thing. The research from Brazil shows that the rate of a malocclusion in future life is decreased substantially if a child is breastfed up until the age of 2. Beyond the age of 2, there doesn't seem to be any extra benefit from a malocclusion orthodontic point of view. But if it's dropped off before the age of 2, then the chances of malocclusion increase. Now, I think on this topic, we need to be very mindful that breastfeeding is a very emotional topic. It's very individual, and there's no sense of judgment in having these discussions. This is purely just conveying what's out there. There are plenty of reasons why breastfeeding may not be successful, and we shouldn't be generating any maternal or parental guilt in this arena. But that's not to say that we can't advocate either. And certainly, with the circumstances prevailing where it is going well and is to be encouraged, this is certainly one of many benefits of breastfeeding that can transpire.
I can vouch that that's true because my mother had 7 kids, and she listened to all the marketing and thought she was upgrading and spending hard-earned money to get better. And so the first 3 kids were all formula, and I was number 3. And then the next one, Kayleen to Paul, who lives out in Sydney, by the way. You're up in Brisbane. He moved to Sydney, and he's already a citizen, never come back. He loves that country so much more. And but anyway, when she told me, she came downstairs in my room and woke me up. I was in high school, and all of a sudden my mom's in my room and she's crying and she's telling me this, and I'm just like, yeah, you're good, Mom. Don't worry about it. But it really was playing on her mind, and I just thought, wow, this woman must have been thinking about this a long time. So it is a weird topic because in this country, I think it's so bizarre how you can have a Rambo movie where 100 people get killed with a machine gun and it's rated PG-13 for family. But man, someone whips out a mammary gland and now it's rated R. And it's like, how could a machine gun be okay, but breastfeeding? And then I've had dentists get mad, or patients get mad because someone's breastfeeding in the office. And I said, well, how old were you when you were born? That's what I always say. Same thing. How old were you when you were born? Because I know that I couldn't eat with silverware when I was born, you moron. But man, this is really getting to be big. And what I think is weird is, you can't see it until you see it. And after I took my first sleep apnea test, it seems like several times I've been over to someone's house and they have like a kid or a grandkid that's passed out on the couch sleeping, and you can just tell that this kid has huge problems. And how did I get to be 40, 50 years old before I even noticed it? How does a person get trained in that? That's the next big question. How would they learn more about this?
Yeah, well, it's one thing that David and I have been trying to work on, and we're actually working on a book right now, a textbook with some pretty heavyweight experts in the field. Dr. David Gazal is a pediatrician at the University of Missouri, and he's an MD. He wrote the book on pediatric sleep medicine. Another guy we've got is Jerry Simmons, who's an MD. He's triple board certified in neurology, epilepsy, and sleep medicine. And Uma Katwa is another pediatrician at Harvard. And so we're putting this thing together because, there's a lot of, and David can, kind of chime in on this too, but the whole thing with sleep apnea kind of started in adults. I mean, that's where it began. It's Dr. Gimeno and Dr. William Dement discovered it. It's mainly in obese men. That's kind of where all that started. And then in 1976, Dr. Christian Gimeno discovered it in children, that it occurs in children, not just obese children, but it can start as early. I mean, you can start seeing it developing as probably even when they're born or 2 or 3 years of age, and then leading to the comorbidities that kind of develop down the road in adults, such as type 2 diabetes, heart disease, stroke, those kind of things. So that's what got my attention early on. As I said, well, if a child's anatomical makeup, because of they're changing their breathing pattern and they're not being breastfed, because the whole thing about being fed as an infant, it's not just nutrition. It's the effort to get the food. That effort by breastfeeding is an integral part of this whole thing, and the development of the whole nasal maxillary complex and the mandible, everything kind of coming forward, which is kind of a little bit opposite of what we orthodontists have been trained in over, since even my training at Pennsylvania in 77. And even today, it's kind of like maximum anchorage, and you're a great orthodontist if you can hold things back. But it seemed like one thing that kind of put a light in my mind was one of the, quote, cures for sleep apnea in adults is double jaw surgery. Is you take the maxilla and move it out, you make the mandible and move it out. But one key element is you do a genioplasty that where the genial tubercles are still intact with the tongue. And so when you do the genioplasty, everything's coming forward, the tongue's coming forward, and guess what? You're opening the airway up hugely. So it's beside tracheotomy, it's probably one of the cures for sleep apnea. But now in adults, we put the Darth Vader mask, we put the CPAPs on, and that's the gold standard treatment. Only about 50% of people wear it. But then you've got the mandibular advancement appliances that we dentists make, especially in adults. But the whole point is, where does it all start? Where is the genesis of this thing? And it starts in the children. And that's kind of the thing that I'm really interested in, is the pediatric part, because that's where we can have the most effect and treat them earlier. In orthodontics, we say we want to see them around 7 years of age, 7, to evaluate them. And then usually we put them on recall till they're 12 or 14 to do treatment. But at 7 years of age, about 70 or 80% of facial growth is already completed. And by 5 years of age, 50% of facial growth is completed. So early treatment is not really that early when we start really thinking about it. So, but that's the time that you really have the most potential to try to outgrow. You don't want them to grow into it, because getting them out of it is a major problem. You want to try to grow them out of it.
Yeah, and Howard, there are a lot of resources out there, and obviously, as Bill alluded to, he and I are collaborating on a book. But the way that Bill found me is through this wonderful thing called the internet, and it's both a blessing and a curse in terms of what it can be. But specifically, he found me through a Facebook page that's I run. If you look up ENT for dentists on Facebook, it usually pops up. I started running that page from memory in around about 2014. And the reason I started putting that page up is because, again, through this wonderful thing called the internet, I was already doing a lot of online interacting with dentists that are asking these really insightful and helpful questions and questioning what they were seeing. And I think over time, what I've discovered is it's very easy to learn. It's much harder to relearn. So whatever you generally are exposed to first, if it's new knowledge or a new paradigm, that's usually what you take on board. And then it's very hard to shift from that. Even if it's easy to fool someone, it's harder to convince them that they've been fooled. That's why, internet scams are so prolific. So in terms of learning, I think the best place for learning is from people that are not of like mind. So I've learned so much from the dental community, and I would hope that the dental community is in a position to learn a lot from the medical community. But the problem we have is we have too many people that are still holding on to what they were taught 20 years ago. Knowledge changes. And if you cannot change your mind, then you cannot learn. So the resources that are out there, Facebook pages that I run, the books that I've written, they're all geared towards trying to change things. And I take a wide approach. I don't just focus on the dental community. I focus on psychologists, because for child psychologists, because, for example, this condition that we're talking about, and I guess we can elaborate in a moment, but there's this condition called sleep-disordered breathing. If you were to survey 10 medical practitioners and ask them to say, have you heard of sleep-disordered breathing? I don't think 10 out of 10 would answer yes. And if you were to ask those 10 to define it, I suspect 1 or 2 might get close and the rest would sort of be floundering. This is quite shocking, because sleep-disordered breathing as a condition in children is far more common than diabetes and asthma combined. It is the most common chronic healthcare condition in children. And most medical people could not even tell you what it is, and probably as a result could not even diagnose it. So we need to obviously work on the medical community in that regard, the dental community. But I mentioned psychologists, for example. Having sleep-disordered breathing increases the risk, and this is just in children and adults alike, increases the risk of depression, anxiety, bipolar affective disorder, schizophrenia, psychosis, ADHD. It makes ASD, which is autism, worse. Suicidal ideation goes up. I mean, these are shocking mental health implications. So we work at that angle. I work at the education angle for teachers and teachers' aides. Bill mentioned someone called David Gazal. So David Gazal really brought this into the limelight by doing a survey of children in his school district. And his survey was very simple. He basically said, I want to send a letter to the bottom 10% of children academically to their parents. And the survey was, does your child snore and stop breathing at night? Very simple. Where the answer was yes, those children were then given the opportunity to see an ENT, and where appropriate had adenoid tonsil surgery. And then as a result of that, 12 months afterwards, those children that had been identified and had intervention were no longer in the bottom 10% of their classes. So this has a major impact on children's brains and their health and development. So I really hope that through this forum and the many others that we can sort of try and approach, and Bill and I, by the way, Bill, I'm going to throw you in the deep end. We're happy to do these ad nauseum with anyone that's listening that does their own. We're happy to jump on board, because ultimately the best way that we can get this message out is through the internet. And hopefully, from today and moving forwards, there will be a complete shift in the mindset, because I know, and you said the same thing yourself, Howard, once you've seen this, you cannot unsee it. I go and do talks, for dentists and so forth, like a weekend seminar where I rant and rave and so forth, but it's all evidence-based, all the science is there. And I get the feedback, people, like the first day back at work, they say, I have just seen 6 things that I had completely missed in the whole 10 years of my career. Mm-hmm. So, that's how we change, is we have to be open to learning.
You know how you said, once I saw it, you can't unsee it? Well, if my homies are listening to you and once they hear it, they can't unhear it, that's because he was born in the same area as the Bee Gees. In fact, I got to tell you, the most embarrassing thing when I went to Australia, I was so excited. Ruth and George Port of Port Laboratories? Anyway, they had the biggest dental lab at the time, and they'd bring me down every 5 years. I'd do this tour: Auckland, Sydney, Brisbane, Melbourne, Gold Coast, Perth. And it was just cool every other day. And they were always like, are you sure you could do all that? But when I got to the airport, I went to the tourist desk. I said, where's the Bee Gees Hall of Fame Museum or whatever? And she looked at me, she said, we don't have any Bee Gees Hall of Fame. I'm like, well, they're like the greatest people that ever came from Australia. And I was thinking about them, and then just like, I think Americans are into the Bee Gees more than Australia, and we're definitely into the St. Patrick's Day parade more than all of Ireland. But one time I was working out at a Lifetime, and this ENT buddy of mine just came up to me, and he said, "What the hell are you dentists doing with these sinus lifts and implants, man? I just had some person come in. They thought they've had allergies for 20 years. I stuck a camera up her nose, and there's this damn implant sticking in. There's white Canada everywhere. What a mess." And he says, "Leave my sinuses alone. There, you had 2 virgin teeth next to it. You could have filed it down to do a bridge." And I thought, man, isn't that amazing? Since I'm a dentist, I pray to the enamel gods, and I save the enamel, and then went and threw titanium and a bunch of crap into the sinus, and the ENT was like, "No, stay in your lane, man. You're a tooth jock. You stay out of my sinus." What is your thoughts? Do you think dentists were too lackadaisical with the sinus and doing all these sinus lifts and all that stuff? Do you think it's okay, or what are your thoughts?
Very simple. I call it selection bias. People don't come in and see me because they've got a perfect implant. People see me because something's gone amiss. And that's pretty much few and far between. So the selection bias is something that we need to be very mindful of, because, if we were to, think that what we see in our own clinics is representative and expandable across every other case, well, that's just utter and sheer nonsense. Anyone and everyone can point to a case that went wrong in their own hands. That is a reality of life. As we say, the only people that don't get complications are the people that do nothing. So I think, to be honest, with all due respect to the colleague of mine that you're alluding to, I think he's just got to be in his bonnet, and he just needs to get over himself.
Well, in America, we always call you guys ENTs because nobody can pronunciate otolaryngologist. How do you say otolaryngologist?
ORL, otorhinolaryngology. But technically, if you want to get fancy, we actually deal with the throat as well. So we're technically otorhinolaryngopharyngologists.
Yeah, I'm going to go with ENT. Is that a selection bias of being So to the kids though, because a quarter of my listeners are still in dental kindergarten school,
which is fantastic because it's a blank canvas that we can paint on.
Yeah.
We can introduce them to ideas and concepts that they probably won't come across in their university training. And, there's even some university lecturers that will absolutely dismiss this. But again, that's the question of learning versus relearning. So to that 25%, what I would say is that there's a massive overlap between ENT and dentistry. And obviously we're focusing on airway, but I would go beyond that. We can talk about things such as bruxism. We can talk about early dental caries. We can talk about molar hypomineralization. We can talk about malocclusion. We can talk about TMD, TMJ problems. We can talk about dizziness. We can talk about upper aerodigestive tract tumors. We can talk about periodontal disease. People are shocked to learn there's a link between hay fever, allergy, and periodontal disease, but there is. Go look it up. Dental abscesses, sinusitis. The list just goes on and on and on. And if you're not aware of the links between those dental conditions that I've mentioned and ENT, well, they exist, and this is an opportunity again for having your interest stimulated and to learn. And to be honest, with that list I've given, I suspect there's a good number of the other 75% that are sitting there going, I didn't know that either. I'm probably craving for more information, but it's there. You just got to go looking.
Okay, well, start with, I'm just going to ask you some simple, basic questions. What's the difference in nasal breathing and mouth breathing?
Okay, so you've got to sort of pause and reflect a moment, because you mentioned mouth breathing. So let's talk about sleep disordered breathing. So I think, it's one thing for me to criticize people not knowing what it is, but it's remiss of me not to then explain what it is. And Bill partly alluded to this. So historically, we focused on adults with obstructive sleep apnea. They were the group where they stopped breathing at night. And then we realized that kids were doing the same thing, and that fixing the kids with surgery worked really well. Fixing adults with surgery was a bit hit and miss from an ENT point of view, but that's because we were not really using the right tools and the right people at the right time. What we realized, though, in adults and children alike, is that there were a group of people that had all the hallmarks of obstructive sleep apnea, but they had a perfectly normal sleep study in terms of how sleep studies are usually done. So we're sort of a little bit conflicted there, because the study was saying they were perfectly normal, but clearly these people were not normal. And at least in the pediatric setting, we then started embarking on surgery for them, and they started doing better. And then we started to realize there were a group of kids that was snoring. They were also demonstrating very similar pathological consequences in terms of having obstructed breathing. We started fixing them, and they started doing better. And then we saw the mouth breathing children, who again had very similar symptoms, tiredness, for example, being a major red flag upon awakening. And we started assessing them and addressing them, and they started doing better. And that's actually the spectrum now of sleep disordered breathing. It goes from obstructive sleep apnea to upper airways resistance syndrome to habitual snoring to mouth breathing. What's the difference between mouth breathing and nasal breathing? There's a multitude of physiological differences, but I'm going to give just one simple one just to sort of get the message across succinctly. When you breathe through your nose, most of the air that you breathe in goes towards the bottom part of your lungs. When you breathe through your mouth, there's more air that goes towards the top part of your lungs. Most of the blood flow is through the bottom part of your lungs. So for the air, and in particular the oxygen and gas exchange to be efficient, you need the air to go where the blood is. So breathing through the nose puts that air to the bottom part of the lungs. So physiologically, that is a good match. Breathing through your mouth puts it towards the top of the lungs. Physiologically, that is a bad match. So just by that one thing alone, the oxygen levels drop. There's a whole sequence of things that then follow on from that. Increased rate of breathing, also increased sympathetic nervous system activation, and also we can measure changes in brain physiology in response to these changes as well. So, for example, there's a cardiovascular compensation where a greater amount of blood is diverted towards the brain simply because the brain is aware of the fact that its oxygen supply has been compromised. And these physiological changes add up over time. 25% of children with sleep disordered breathing have high blood pressure. Okay, that's a significant statement in the medical arena that most children are not diagnosed with, because most doctors don't even know that statistic.
On Dental Town, I posted your two books, but anyway, it was a thread. What was it called? Airway Orthodontics, and you were telling them. You said, as a pediatric ENT, I would always advise to get the breathing sorted first. And Sulk916 says, what do you mean by getting the breathing sorted first? Learn to breathe through her nose with large adenoids? Is it her nasal passage narrow, and that's why the child is breathing through the mouth? Don't you need to enlarge the airway first before correcting behavior? What do you think on that?
Happy to walk you through that. That's a really good question. So when we do mouth-to-mouth, resuscitation and so forth, we talk about airway breathing circulation, okay? So in this context, I talk about airway, braces, complementary, okay? You don't go to dental before you go to airway. In mouth breathing, and this I think is really important for people to understand, because this is where the lack of communication and then the paradigms of things have complicated things, and we need to unravel this. Mouth breathing, particularly in children, so let's start, because as Bill said, this is where this all starts. In mouth breathing, 80 to 90% of mouth breathing is due to some form of physical obstruction, the majority of which is related to the adenoids. But the other two structures that can be the middle portion of the nose, called the septum, can be crooked. And also then the side walls of the nose, there's a structure called the turbinates, inferior turbinates, and they can be enlarged. And in particular, they'll be enlarged because of allergy type things that result in an immune system that results in swelling and congestion of the lining of that mucosa. It swells up and blocks the nose. So 80 to 90% of mouth breathing children is because of a septum, turbinates, or adenoids. So you cannot train around a blockage. Okay, and I used a host of analogies. So if you're at home and the kitchen sink is blocked, you expect the plumber to clear the pipes. That's the first thing to get things functioning. In adults, what we do is we put them on CPAP, which is the equivalent of the plumber just coming to the kitchen sink, installing some big industrial pump, and just saying, don't worry, it'll just force it through the blockages. Don't worry about the blockages. People wouldn't accept that as a management at home, but they happily accept that for their health. From the point of view that's been asked about, widening the nasal passages, so that's with the maxillary expansion. This is where I might upset some people, but the research shows that maxillary expansion does not increase nasal capacity. What it does do is it reduces nasal resistance. So that's clearly a good thing, because reduction of nasal resistance does then facilitate breathing through the nose. But there's no good getting the nose unblocked if you've got a chunk of adenoids sitting right behind it. The other important thing, and I think Bill would agree, is that when we talk about maxillary expansion, what we also need is maxillary protraction. We need the maxilla coming forwards. We don't just want the maxilla going out. We need it coming forwards as well. You need to change the obstruction, though. The people will say that expansion can straighten the septum. I know there's a few papers out there. None of them are overwhelmingly good. And my general experience is that there's so many different types of septal deviations that you can't win with everything all the time. You've got to work as a team. If they've got hay fever and allergy problems, well, you can open up the nasal passages if that's your belief, but the swelling's just going to increase and take up even more of the space that you've made. So to address mouth breathing, you need to make sure an ENT has looked and addressed the causes. Once the causes are addressed, then you need a little bit of time for things to reset. Brains have plasticity. They can reset and relearn. Takes a couple of months. And then you can start working on the jaw deficiencies. Then you can start working on the retraining if that's appropriate. But, you would not train an elite athlete with a broken leg by making them run. You would have to wait for that broken leg to heal up first. It's the same thing with a blocked nose. You cannot train someone to breathe through their nose when it is blocked.
I'm going to go to a whole different area. All these dentists, it's a CPAP machine or oral appliances. Can you just rant your thoughts on CPAP versus oral appliances?
Yeah, really easy. It's the wrong argument. This one or the other is a nonsense, absolute nonsense. The reason for it is that, and this is the advantage I have as an ENT, is I get to look inside the nose and inside the throat. And in doing so, I can get them to bring their jaw forwards and simulate what a splint could possibly achieve. And I can see, does that stabilize the airway, or does it make no difference at all? If it makes no difference at all, a splint's not going to do a world of any good whatsoever. CPAP is an excellent treatment that most people don't stick with. And the most common reasons they don't stick with it is because they never felt they had a problem in the first place. They don't understand why they have a problem in the first place. Or they've got some form of anatomical obstruction that means that the CPAP needs to be turned up higher. One of those places of obstruction is the lower airway, and a mandibular advancement splint can improve that lower airway. It may improve it enough that they don't need CPAP, or it may improve it enough that the CPAP is then better tolerated because the pressure levels are low. So I don't play the one versus the other. I sort of have an approach and go, right, let's optimize the ENT things. If a splint's going to help, let's do that. And then let's reassess. Is that enough? If it's not enough, all right, we're going to need the CPAP. But the CPAP's going to be well tolerated, and this person is set up for success. Putting a CPAP onto someone that has significant lower airway compromise, significant nasal obstruction, you're setting them up for failure. And once people have learned that it's no good, they will not go back and try it again. Even if you optimize everything, you've burnt that bridge. So I don't play the versus game. I play there's a bigger market out there for people, that people that are trying to get people onto splints instead of CPAP. Try and get them onto a splint with their CPAP. You get an even bigger market that way. Bill, you've got a lot of experience with this. Would you like to reflect on any of that?
Yeah, I think you're exactly right, because we get a lot of people, adults, that are referred by the pulmonologist. A lot of my patients that that are referred to me have already seen a pulmonologist or an ENT, and they've had a sleep study. They have documented sleep apnea, but they're intolerant to CPAP for whatever reason. I was claustrophobic with it. It just made me feel claustrophobic. Let me give you a little personal example. When I was first diagnosed with sleep apnea, a number of years ago, we tried a CPAP, and I just never could. I told the doctor, I just said, I feel claustrophobic with it. And the pressure was pretty high too. And he said, well, I hear that, but I don't necessarily believe it. So I put myself with a CPAP in my cone beam machine, and I turned it on, and I took a cone beam. Now, guess which airway was smaller, my original or the one with the CPAP? One with the CPAP was smaller airway. I guess because of the turbulence or whatever. Because what I find a lot of times, these patients that are referred in because they're CPAP intolerant, not that the cone beam is the end all be all, because it is an upright and awake airway. But if I find a very small airway that's big as my little finger, upright and awake, and they're CPAP intolerant, I go, well, there's part of the problem, because you're trying to force that air into that. You're trying to take a fire hose and you're trying to blow it down a soda straw. And it just doesn't work. So why, like David said a minute ago, why not make the soda straw bigger? And then you probably can tolerate the CPAP better. That ought to be, the treatment is the combination. But insurance companies get in the way of some of that. So we just, that's a little thing you got to fight too. But I think that's why I've concentrated more on the pediatric side. Is there things that I can do as an orthodontist, expansion, forward movement, whatever, mandibular advancement, not on everybody, but that seems to at least get the room bigger. So if you got a lot of stuff in it, at least the room's bigger. Now, but then if you've got a lot of, you've got the adenoids and tonsils and deviated septum and the turbinates, you got to take care of that. Like David said, you've got to take care of that soft tissue part of the obstruction, because you just kind of dog wagging his tail if you don't. Does that kind of sum it up, David, a little bit?
Yeah.
That's why I got David on, because David understands, he's an ENT, but he understands dentistry a lot. I'm an orthodontist, I understand that, but I don't understand all the ENT stuff. I'm trying to learn more and more, but that's the dentist and ENTs need to be tied at the hip.
Well,
I mean,
that was going to be one of my next questions. One of the referral dilemmas I had when we started TMJ and all that kind of stuff, and going through Pankey and Dawson and all that back in the 80s, is the dentists, since they were dentists, all their referrals were, went to dental school. And looking back 32, 33 years later, I knew stress had to be some part of, it has to be in there. Everything's multifactorial. And if it was a guy, I had a psychologist for a guy. I said, maybe, I don't know, maybe stress is related, but you ought to go talk to this guy. And if it was a lady, I sent her to another one. And fast forward 30 years, some of the most profound things that a patient stopped me and said, by the way, I want to tell you, I've been coming here for a long time, but the greatest thing you ever did for me, you sent me to John 10 years ago because I was grinding my teeth and you made me this night guard, but you said, maybe you should go see this guy. And I've had, especially with the guy, I've had 5 or 6 patients just said that was the biggest life-changing thing they did. And so my question to you is, when should a dentist meet an ENT, and how would you start that relationship? Because what % of the dentists do you think listening right now have never ever referred one patient to an ENT?
Probably majority.
I'd say most of them.
Yeah, the majority of them.
Yeah, but the other thing might be too is that they might have tried, but the ENT is oblivious and unaware of what the dentist is worried about is actually relevant to the ENT as well. So that can feed into it. The problem is, at least in Australia, I assume it's probably similar in the US, Medical people and dental people do meet each other early on. The first year or two of university, there's possibly some common lectures that we all sit amongst, and then there's a divorce. And the divorce is that the teeth don't belong to the body anymore. So the dentists take possession of those, and the medical people take possession of everything else. And as a result of that, there's absolutely no way that we'll ever talk to each other ever again, because we've parted on those terms. That's a failing of our education, and our education then forms our mindset. And if you just pause for a moment, and if you were to sort of talk to someone with some sense of logic that's not in this industry, and said, did you ever know that dentists and doctors hardly ever talk to each other? They would be like, what do you mean? It's like, well, there's so many health things that go on that they're intertwined. It's not like the teeth that somehow don't exist in isolation. So I would, again, hope that for those that are already working with an ENT, it's because they've found an ENT that gets it. Not every ENT gets it. And then I think that's important too. Not every ENT does this. Just like if you were to send gum disease to an orthodontist, they'd probably be scratching their head going, well, I don't know why I got this case. ENTs might be focusing on ear disease, and then they sort of go, well, I don't know why I've got this sleep apnea case. So you do need to realise that ENT in itself is a big specialty, and that looking at every ENT is the same would be like saying every dentist is the same. There's a big difference between what Bill does and what a maxillofacial surgeon does, but they're still dentists.
So I want to switch gears again completely. You wrote a book. Now, your first book, my gosh, Don't Ignore the Snore. And it's clearly all non-capitalized letter, even on the book. But everybody I've ever seen, oh, you got to check out this book, they capitalized all 4 letters, not just the don't. But so talk about Don't Ignore the Score. And I'm weirdly wondering why it's all uncapitalized. And then your new book, Snore to Death. Are you dying in your sleep? Talk about those books. Why did you not capitalize Don't Ignore the Snore? Was that
because basically the topic is belittled in itself. So it's representative of how the topic is perceived, is because it sits there in the background with people really not having it of any attention to them. So it's representative of that being the case. So that for people that get that subliminal message, good luck. But that's the premise to it. And the reason for Don't Ignore the Snore is basically to put, I think from memory is about 60 odd health medical conditions that relate to airway obstruction. I didn't put them all in. There's a lot more I could have put in, but I thought 60 was a good number. And it covers a whole lot of body systems and then has some science behind it. And so forth, so that you end up with, I think, close to about 200 odd references across multiple specialties, multiple medical scientific fields, highlighting the impact that it has within the little silo of health that people may be interested in, whether it's your heart, whether it's your bladder, whether it's your prostate, whether it's your brain, your eyes, your bones, just cover that spectrum of things. The reason for Snore to Death was because that's very much what people are doing. Snoring is a sign of airway obstruction. Airway obstruction means oxygen deprivation. Oxygen deprivation is not good for the body. People that snore die sooner than they should. People that snore have a lot more in terms of health problems than they should. Particular things like diabetes, high blood pressure, for example, but a whole host of things. And the structure of Don't Ignore the Snore is similar to what we've just been covering here, is to try and just give people an understanding of what's going on beyond the old, oh, it's big tonsils and adenoids in kids and it's the tongue falling on the back of the throat in adults. It's far more complicated than that. It's far more intricate than that. And I've written it basically so that it is an easy read and it's comprehensible and it's structured so that you can walk through and see how these things all start to pile on each other. Perfect example would be reflux. Reflux causes problems with upper airway obstruction because it causes swelling on the back of the tongue, it causes swelling of the adenoids, it causes swelling of the tonsils, and it causes swelling of the nose. That's all 4 airway points of significance. Reflux does that. And it could be the dentist that's seeing reflux changes on those molars and so forth. That could be the first clue to the fact that there's even reflux there in the first place, because it could be a low-grade reflux that we call silent reflux. So they're not getting heartburn, they're not getting the indigestion of GORD, but they're getting reflux, or GERD as you call it. Sorry, that's the Australian and American spelling again, GORD versus GERD, showing up. So that's sort of the premise of the books was here's the science, and then here's the logic.
No, that's very interesting. Bill, I was wondering. You've been doing this for a long time. I'm not calling you old, but you've been doing this from a long time, and I'm just wondering how flexible and open-minded are the dental schools in your backyard. I mean, you're out there. What does Russell Teichman at the University of Alabama School of Dentistry? What does he think all this? Or the Mark Wolf, Chung Chung of the director of orthodontics at Penn State. I mean, are they looking at this and agreeing, or are they old school, or how modern are the institutions?
Yeah, that's a great question. You have to kind of understand the educational process of an orthodontist. We're there, and I teach at UAB. The residents are there for 3 years, and the curriculum is set up so you get a lot of basic science and growth and development and all that. But as far as patient care, you are expected to treat your cases and get through with them in 3 years. I mean, by the 3-year stint you're there, you get some cases, some minor cases that are started in the first year, and they get a little bit more complicated as you go. But by the time you don't really want to transfer out that care to another resident. So you're trying to get all that established. Well, you can't see kids. There are some kids that come in with cross bites, or maybe underbites class 3 or class 2 early, that we might get a little bit of early treatment, quote unquote, early treatment with expansion with RPEs to get rid of cross bites and things. But that's about it, and you have to understand that educational system, because they can't see them at 4 or 5 and follow them through the whole gamut. So that's kind of one of the things that I'm doing there, is I'm showing them my cases. Okay, here's a 4 and 5-year-old. This is the screening. Here's some of the 3D biomarkers that I found on the face. This is what the cone beam looks like. Because a lot of even the universities today, even though they may have cone beam CT, they only use it for impacted cuspids and surgery cases, and that's about it. They don't see. It's an article that David Hatcher and I wrote in 2002 about the anatomic truth. It was published in the AJODO, American Journal of Orthodontics, about do you want adequate imaging? And to me, 2D imaging is adequate, or you want accurate imaging, which to me, 3D patients are 3-dimensional, and you can't assess airway just from a lateral ceph, because that lateral dimension, you've got to look at it from the coronal view and even the axial view, because you can't understand that size and shape of the airway. It may look huge on a lateral ceph that looks like, well, they don't have an airway problem. Well, not that you can specifically say they have one, but the way I look at it in cone beam, I can at least say, hey, you got a smaller airway than normal. And Dr. Schindel and Dr. Rick Jacobson did a study back a while ago. I think they involved about 1,300 to 1,500 individuals that did not have any sleep disordered breathing by questionnaire. And it was from, they took the sample was from 6 to 60. And these were considered normal airway, upright and awake airway on cone beam. So there is a graph, there's an article that Dr. Schindel, he was the chief of plastics, he was the former chief of plastic surgery there at Stanford, worked with all the major pioneers, developed some of the MMA surgical techniques and things like that. Good friend of mine, I've known him a long time. He's kind of retired out of that now, but that's part of where I got, some of my education, I guess, from some of that group. But, that's kind of what got me interested in some of this from the start. And then I started looking back at, okay, look, this thing starts in children. And then that's kind of where David and I kind of crossed paths. And then the rest is history. Hopefully we have a lot of history or pursuing in the future.
Well, you are a history maker. I mean, like I say, you were one of the first people to buy that in Alabama. My gosh. But that was the ICAT by Cavo, which then got bought by Danaher. Then they spun that off as Invista. But now it seems like you're more talking about 3DMD.com. So what's the difference between ICAT and 3DMD.com?
Okay, that's a good question. Like I said, I've always been interested in 3D. Interesting story about how all that started. A colleague of mine is a general dentist in a town close to me now, Dr. Ray Bolt, but he developed some 3D imaging techniques back in the 80s on an Atari computer. And what he did, he brought me, and this is everything, all great things start in the basement of your office. So he called me over one day and said, hey, you got to come look at this. So the Atari computer, instead of being up and down like these screens are, it was laid on its rear end. And so he gave me some liquid crystal shutter 3D glasses. It's tethered to the computer. And he had images that were actually popped up like a hologram, like R2-D2, popped up holograms off of the image. You had people walking around, airplanes flying around, and I'm looking at all this stuff going, wow, wouldn't it be neat to create a skull and a face where I could talk to patients and they could really see depth perception and all that. So that's kind of what got me involved in it. So then when cone beam came on the scene, I had also met a group in Atlanta, Georgia, 3DMD. What that camera does, it does the surface of the face in 1.5 milliseconds. It was invented to take young infants. You put them in a room, there's cameras everywhere, and they put them in the middle, and they put a stocking cap over their head, and it's to create the phagocephaly caps for these children. And so it had to be fast enough because you got an infant sitting in the middle here moving around and everything, but you got 3D cameras in one above, in all the corners of the room and even below. And in 1.5 milliseconds, that quick, it creates this. It takes about a minute to process it, but it creates a real, this is a 3D structure, full color and all that. So Dr. Bolt and I actually went to a meeting. It was a biometrics meeting in Washington, D.C., and happened to see this camera system. So I got talking to the president and the executive vice president. And I said, hey, if I'm going to jump into this 3D thing with cone beam, I'm going to go ahead and drown myself. I'm going to go ahead, because I believed in having the face and mapping it over the cone beam. Well, as I got to looking at things and reading more and more about what are some of the facial when a child walks in the room, you can tell if they got an airway problem just by looking at them. You can see the dark circles under the eyes, the small nose, the mouth open posture. There's a lot of biomarkers. There's 20 or 30 of them that I've kind of defined, but all of them have geometry, size and shape, linear distance. They're all measurable on a 3D image. So in 2005, I was probably one of the first practitioners in the United States I know of, or maybe even the world, to have both of those at the same time. So then I started thinking about it. I said, what if we not only have a screening form, which I'm on the American Dental Association's called Children's Airway Screener Task Force. We're trying to come up with good screening tools that is sanctioned by the ADA anyway. But then I started thinking, I said, well, if we could create a 3D camera and create a software program where we take that image of the face and have it run through an algorithm that says, okay, your child's got grade 3 allergic shiners. They've got small nares opening. They got a long facial pattern with the mouth open posture. Even the eyes, there's certain things about the eyes. Like I said, there's about 20 or 30 different biomarkers, so to speak. And so that got my attention. Now I can do that now, but it's all manual. So what I'm kind of looking at is if you could take it into a school. Let's say you take a school and you take the 3D camera, and maybe now you've even got iPhones and that can take that. But you take the image, run it through an algorithm, then it prints out a report, says your child's got, 10 of these 20 biomarkers. You need to go, it's suggested that you see an ENT or take this piece of paper, the orthodontist and the ENT. So that's kind of what got me. The 3D MD is it's just a facial surface, but it's accurate to like a 1.5, it's accurate to, it's very, very accurate, and it's quick. It's 1.5 milliseconds, less than 1/10 of a millimeter accuracy, which is amazing. And you can there are ways now to be able to map that face onto the cone beam. So you have a true face, not just a photo wrap. Right now, some of the softwares, you take a 2D photo and it's like putting it on a piece of saran wrap, just stretching it over the face. You're taking an accurate cone beam and you're boogering it up by putting a 2D stretch photo over it rather than a true 3D face. So that's kind of what got my interest in having both systems.
What I think is really interesting is the 3D MD, it says it captures 4D anatomical shapes.
Yep.
Because in Einstein's fourth dimension of time, that by filming this at 120 frames per second, you can see it now.
Absolutely, and that's kind of what their concentration is now. They've kind of got away from the static systems, but they got some amazing stuff because you can. What they're concentrating on right now is athletic wear, like golfers. I mean, you put a full golfer in this room who's got all these 26 cameras or more, 30 of these cameras, and he can take a swing with his golf club, basketball player, whatever. So they're looking at how the clothing, drapes over those athletes. And you could do speaking and chewing, and I mean, it has dental applications. It's not cheap, but they're doing a lot of this in some of the bigger research, units to actually look at facial expression, and it's amazing what some of the things you can do. They're
David,
looking at even genetic patterns on the face is what they're even looking at.
David, were you actually named after the McIntosh computer? Was that
when I was at school, I told kids that, but they were naive enough for me to get away with it at the time.
But I can remember clearly that the Americans thought that an ulcer was something that needed to be cut out, and they were cutting these all out. And it was a physician in Australia that said, "What are you doing?" and couldn't figure it out. And she was saying it was H. pylori bacteria. And then I'll never forget. And I don't mean to embarrass you by this or anything, but it was another Australian physician after a child had chemotherapy for leukemia and was laying there lifeless, and her brain went off, and told her mother, "Can you give me a bowel movement?" And she gave her a fecal matter transplant. So you can imagine the jokes on late night television in the United States just blew off the charts. And now Mayo Clinic up the street from me, I'm here in Phoenix, next door at Mayo Clinic. I called my guy over there, and he said, "Yeah, we're doing fecal matter transplants." And I mean, Australia has always been a outside the box. I assume it's because it's a 17-hour flight from LA to Sydney. And if you think Sydney is really cool, I love where you're at Brisbane for that, but actually what I liked the most was flying the other, like landing in Sydney would be like LA. Then you fly all the way across the country, and there's Perth. And I mean, I thought Perth was the most unique civilization I'd seen, and the dentists had the most unique thoughts simply because they were 5 hours away from Sydney, which was 17 hours away from LA. And I think they were just so isolated that they had original thoughts. But why do you think these two big H. pylori bacteria and fecal matter transplants, why do you think they came out from down under?
Well, I'll give you a little bit of insight. So Perth, people want to look it up on the map. It is the most isolated city in the world. So if you look at any other city in terms of where its next closest city is, Perth is the most isolated city in the world. And I think, you can sort of just look at that just at any sort of community level. Like when you drive through the United States, it's united by its landmass, but it has so many cultural differences, even from one town to the next. And I think in identifying and developing your own sort of identity and culture within a town, you can also then start to identify and start thinking. So, this was sort of my life too. I thought I was really clever. I can distinctly remember in 2007 doing a talk to the medical doctors in the town that I was living in at the time, saying that, look, I think I've discovered something. I think that all these adults that we're using mandibular advancement splints in because their jaws are deficient, that's the same thing we're seeing in these mouth-breathing kids. And I think, the whole world has missed the fact that, these mouth-breathing kids are turning to adult sleep apneics. So, I was patting myself on the back for my absolute brilliance. And then, of course, I start coming across one dentist, then the next, and then a multitude of others, and realized that my ideas were not novel or unique. But my thought process to develop that thought and knowledge was unique in that no one had shown me that. And I think that's basically the same as what you're alluding to, is that people, if given the time to sort of think away from, again, what they've been taught and what they've learned, if they're giving their own time and independence, can actually come up with these insights. And just like, I've had this dawning of realization that I wasn't as clever as I thought I was. But having said that, that's not to demean the fact that, I've made these observations. You can ride the coattails of others before you, and then you can sort of ride your own show as well. So, and then in doing so, you might find that, look, someone else beat you to the punch and so forth. So, we talked about how Stanford discovered sleep apnea. And it's the tumor to Guillermo. The reality is, he was just picking up on stuff that's in the literature 100 years before he was born, and so on and so forth. So, we were sort of not so much discovering, but rediscovering and relearning and re-identifying with knowledge that is already out there. And then we just need to bring it back into the mainstream. And that's the problem with a lot of this, is that it's peripheral. The stomach ulcer thing. I mean, that I remember going through that history of time, and it was just absolutely, without any pun intended, poo-pooed as an idea that you could treat stomach ulcers with antibiotics. That was just an absolute nonsense. I went through, the surgeons were teaching us about all their surgical procedures for stomach ulcers. And, the fact that some antibiotics could fix it was an absolute nonsense. And there was a lot of resistance to it as well, because it meant the livelihood and so forth of people with a vested interest in maintaining certain procedures was going to be compromised and challenged. The cardiologists had the same problem when they developed stents for blocked arteries. The cardiothoracic surgeons were seeing their incomes evaporate because there was another way of doing this where someone didn't need to have their chest, completely opened up and intricate surgery done. You could do it through, a stab in the groin. The history with the fecal implants was transplants, was that in that, when the claims were made, when they put it to a randomized controlled trial, they actually had to stop the trial early because their outcomes were so overwhelmingly in favor of the transplant that ethically they could not continue the trial anymore and give people the traditional antibiotic treatments because they were just so inferior. So, at some point, people, want evidence and want to be convinced, but even when the evidence is there, you've got to put away your bias and you've got to put away what you were told, and then as soon as someone says, but I thought, what you're really saying is, I have already decided that this must be right. And therefore I've automatically decided that you are wrong. You need to get past that mindset if you want to make progress.
I can't believe we went over an hour, but I can't let you go without asking. I know we're in the middle of a pandemic, last year, and dentists are emailing me saying, ask your guests, hold them their feet to the fire. Would you take the vaccine yourself today?
I already have.
Take the vaccine. Oh, I think Bill, you're already one ahead of us on that one.
I've already taken both.
Yeah.
I've gotten the number 1 and number 2 Pfizer. I've already taken it. Didn't have any negative other than just a sore arm. But yeah, I've already bit the bullet and taken it. Didn't have any problem. I don't know what going over in Australia. Yeah, David's probably too young to take it right now.
Yeah, well, yeah. So we haven't even got the vaccine here in Australia yet. It's only literally been approved, I think, in the past 24, 48 hours by our regulated equivalent, your FDA. But it's been approved. We're looking at the AstraZeneca one. Seems to be the one that is predominantly going to be there. I think it's because it doesn't have the cold chain supply issues that the Pfizer one has. And they're looking at the numbers very, very critically. Australia has one of the most stringent drug regulation bodies in the world. Things that you guys can buy off the shelf in Walmart. Some of those things we can't even buy in Australia at all, not even on prescription. Because they're just not sanctioned. So sometimes I do some Amazon shopping just to get some stuff because it's the only way of getting it. But the short answer is that we're living in a very difficult situation. I think we all want to just basically get back to normal. We are experiencing something that reminds us of the world that we live in. We have forgotten about polio. We have forgotten about smallpox. We get reminded of things, like measles and so forth, when there's a cohort of communities that, again, make their independent decisions that they're somehow got protection against what nature has to offer. But this is a reminder that we're all playing a game against us versus nature, and nature ultimately is going to win because we're not destined to be here forever. And we can agonize and protagonize as much as we want. But ultimately, look, you've got one ride, you might as well enjoy it. And if there's things that are out there that can give you a better chance of being here and making the most of what is a ridiculous situation. The fact that, we even exist in the first place is just such a ridiculous proposition in the whole context of everything. Look, I think people need to find better things to worry about than things that can then make them better at the end of the day.
Well, you know how you could get the Australian approval process to go faster? You need to increase the political donations. Money's the answer. What's the question? I mean, you sound like you're all into this science data stuff. Don't you know that to get a bill passed in Congress starts with a $1 bill or $100 bill or $1 million bill? Last question. What has surprised you the most about this pandemic? I'll start. when I got out here in 80, I graduated in 87. And I got, I started practicing, and I was very confused because in dental school, the hardest requirement to do was your pulpotomy and chrome steel crowns. And some rich dentist died, and they took the money, and they had a school bus. They go to the poor schools. They'd bring them in on Tuesdays. And damn, you just could never find a pulpotomy. And you'd ask the kid, do you brush your teeth every day? No. Do you floss? No. They're just poor, and they were adorable, and they didn't brush, didn't floss, they didn't have any cavities. They sure as hell didn't need a pulpotomy. Anyway, long story short, I graduated, moved out here to Arizona. Now, the school I was in was a predominantly African-American community. And then I was out here, and it's predominantly, Arizona on the border. Mexico was like Hispanic and European, and about 10-15% African. And it was just pulpotomy city. And I was just like, and so I started looking into this, and I called the office dental health guy, and I said, what is the deal? Is it demographics, money? What is it? And he goes, no, dude, it's water fluoridation. They don't have water fluoridation. And I was demoralized that I was just going to sit on an assembly line and drill, fill, and bill from 8 to 5, 5 days a week, from 25 to 65. And so we started this Arizona Citizens for Better Dental Health, and I canceled all my Fridays because I was so young and dumb. I thought, well, this take like 3 weeks to get passed, right? There's only 8 city councilmen. And Calvin Good, one of the 8, just died like a week ago. And I started talking to him, and I didn't realize how much of America doesn't care about science. When I would tell a congressman about the Centers for Disease Control, he'd say, well, they're just a shill for the pharmaceutical company. And I mean, I never had been, I had my mind blown that 1 out of 4 people, the more research and articles you gave them, the more they repelled. And then that expired in 20 years, and it was the same 1 in 4. And then this pandemic came out, and all these people were shocked, like, God, where are all these crazy Americans coming from? And I'm thinking, well, you never did a water fluoridation campaign, but I mean, my God, people are very complex, and they're very emotional. They're very tribal. I mean, they're sapiens, and sapien is a love him to death. I wouldn't want to be born in the middle of Australia with no other people and live out my existence. That would have been weird, to say the least. But what was the big takeaway on this pandemic with you and your observations of just dealing with humans?
Look, probably two observations. One is how extraordinary it is that it has affected different countries in vastly different ways. So a lot of I love America, but a lot of your people in America are probably shocked to learn that, throughout this whole pandemic, which is sort of counting 12 months, I think throughout that whole 12 months, I've had to wear a mask less than 10 times. We've had some shutdowns here and there, restrictions here and there, but in the big scheme of things, in Australia, we've been pretty, well, we'll call it luck, in terms of the numbers. We haven't had our hospitals overwhelmed. We haven't had an overwhelming number of deaths and so forth. And we haven't replicated the scenes of places like, for example, Italy and so forth that we saw early on. So that's probably one thing. The second thing is, I think this has genuinely exposed the frailties of life and highlights how very, very important it is to look after one's health. And when you don't do that, when something like this comes along, you're in the firing line. And what has surprised me is the complete lack of advocation by the governments here and elsewhere on general health measures. All right, it's time to start eating better. It's important to get some exercise. Being overweight is no longer the thing that can be normalized as being okay. Good sleep is important. There's been nothing along those lines. If anything, they've shut down the gyms and so forth, and they've created social angst and anxiety by compromising people's incomes. And they've taken away the restaurants and so forth that led to socializing. And I just wonder if there could have been a happier medium. And look, I totally understand that everyone's on a learning curve with this. I just hope someone's taking some really good notes for next time, because there will be a next time. Maybe not in our lifetime, but there will be a next time.
Mm-hmm.
Yeah,
point.
I was just so excited that I'd rather have all of us attacked by another species as one than like World War II or somewhere. I'm just so glad we're fighting a virus I can't see. I'm just so glad it's not a human. But I always remember what doesn't kill you makes you stronger, and it took a global pandemic to make a lot of people in America and around the world realize that every decision you make has a trade-off. And because too many people think of right and wrong, like everything is left, right, up, down. And I like engineers. Everything's a trade-off. Get away from this right and wrong. What is the trade-off of this decision? And I think you really have to get knocked off your horse before you think, damn, I didn't even know I could get knocked off a horse. And and when I was little, I remember the first time I got knocked off a horse. You can't even make this up. The horse was named Lightning, and I landed on the electric fence. And it was at David Huff's house on the Rock and R Ranch, and his dad, I was all crying, bawling, I was ready to just, my life was over, and boy, by God, he was so mad. I had to get back on that damn horse right now, and he didn't give me any crying time. I couldn't stand there and just bawl for an hour. I had to get right back on, but it's I think America definitely got bucked off its horse, and I think it's going to make a lot of people scratch their heads, go back to the thinking wheel, and if they can just get off their high horse of I'm right and you're wrong and just say, okay, what are the trade-offs of this decision? You know what I mean? And interesting times, but gentlemen, I cannot believe I got you two to give me an hour of your life to talk to my homies.
We enjoyed it.
And I enjoyed it immensely. And I hope if you ever run into a Faran in Australia, I think my brother's the only one. FAR. It's kind of weird. It's far ran because I've never ran far. And but God, he loves it down there. And I have to tell you, I've lectured in 50 countries, most of them several times. And your country, Sydney, is the only country where every time I get done lecturing, I'm asking myself, why the hell am I coming back? I mean, my brother doesn't even have a car. There's a subway. I mean, you walk out his front door and, God, there's restaurants and bookshops. I mean, I always tell him I could walk out my front door, lay down naked on the front of the street and just sleep there, and maybe someone would call the police. But that's about, God, the lifestyle and the culture and the restaurants and the bars and the bookstores and the people, my God, that is I don't blame my brother for not coming back. Of course, he left. We're from Kansas, which is considered the armpit of America. It's not like he left L.A. or Miami. But so, David, you live in a great country. Thanks everyone for coming on, and I hope you have a rockin' hot evening.
Thank you again.
Thank you for inviting
morning
us.
to
Thank
you.
you. Appreciate it.
Thank you. Have a great day.
Okay. Thank you.